Hello everyone, this is Amani Al-Ghadani. I am a pediatrics OMSP resident R2. Today my presentation is about acute kidney injury. Specifically, I will discuss about diagnosis of AKI, treatment of AKI including fluid and electrolytes management, and prognosis and long-term outcome of AKI. Now let's start with the first part. The diagnosis of AKI is made clinically based on the presence of characteristic signs and symptoms and laboratory findings indicative of an acute change in kidney function. Signs and symptoms that result directly from alteration in kidney functions include edema due to progressive fluid accumulation, decrease or no urine output, gross and microscopic hematuria, and or hypertension. Laboratory findings include elevation of serum creatinine and blood urea nitrogen level and or abnormal urine analysis. Further evaluation focus on identifying the underlying cause and or contributing factor is important in AKI. History provides insight into causes or risk factors for pre-renal AKI, including decreased circulatory volume in gastroenteritis and hemorrhage, redistribution of circulatory volume in edematous state, nephrotic syndrome, and sepsis, decreased cardiac output in heart failure, or increased systemic resistant in abdominal compartment syndrome and renal artery stenosis. In previously healthy children, the history and physical examination may offer clues to the underlying intrinsic renal origin, including recent viral illness or sore throat, possibly consistent with acute glomerulonephritis, or rash, swollen joints, suggesting a systematic disorder such as lupus, or hematuria or medication exposure. In a newborn with suspected obstruction, a good prenatal history is important. For example, abnormalities in fetal ultrasound including enlarged bladder, hydronephrosis, or decreased amniotic fluid may suggest posterior urethral valve in male infant. In older children, it's important to look for signs of obstruction including complete anuria and poor urinary stream. When evaluating AKI, it's important to remember that an increase in creatinine typically occurs up to 48 hours after renal injury and may reflect events that occurred 2 to 3 days earlier. Therefore, it's important to review episodes of hypotension, hypoxia, sepsis, surgery, contrast exposure, and drug exposure that occurred 48 to 72 hours before the episode of AKI became apparent. The physical examination should include measurement of blood pressure, assessment of fluid status and edema, and the signs of underlying cause or risk factors. The presence of the following physical findings often point to a specific underlying etiology, like signs of volume depletion, edema, hypertension, renal disease due to systematic causes, palpable enlarged kidneys, and signs of obstruction. For the laboratory evaluation, we need to send sample from urine to check for urine analysis, urine sodium creatinine, and urine urea, and from blood to check for serum creatinine level, electrolyte level, CBC. Complement level depend on our underlying cause. And other additional investigations include renal ultrasound and renal biopsy only if indicated. Serum creatinine is the most common laboratory test used to identify and reduce GFR as an indication of AKI. However, serum creatinine level only accurately reflects GFR in patients with stable kidney function. So what's important in the setting of AKI is elevated level of creatinine compared to the baseline, and we need to keep in our mind that normal serum creatinine level vary depend on the age, gender, muscle mass, nutritional and hydration status of the child. The fractional excretion of sodium is a commonly used test to differentiate between pre-renal AKI and intrinsic disease due to acute tubular necrosis, and FENA is calculated from measured concentration of urinary sodium and creatinine and the plasma sodium and creatinine through this formula. FENA is a direct measurement of kidney handling of sodium. So FENA below 1% suggests pre-renal AKI, in which the reabsorption of almost all of the filtered sodium represents an appropriate response to decreased perfusion, and FENA above 2% suggests ATN. FENA between 1 to 2% is non-diagnostic. However, in neonates, especially preterm infants, sodium reabsorption is decreased. As a result, the FENA cutoff values differentiating pre-renal AKI and ATN in neonates are higher. Other tests that have been used to differentiate pre-renal AKI from ATN is urine osmolality. In pre-renal AKI, due to a normal response to reduced renal perfusion, is a prediction of concentrated urine with urine osmolality more than 500. In ATN, due to the loss of the concentration ability of the nephron, urine osmolality will be reduced to less than 350. Other tests that have been used to distinguish pre-renal AKI from ATN is urea nitrogen creatinine ratio that is markedly elevated to more than 20 in patients with pre-renal AKI, whereas in patients with ATN it remains in the normal range of 10 to 15, and the difference is due to the avid urea reabsorption by the proximal tubule, which is not permeable to the creatinine. Urine analysis with urine microscopy can point toward particular diagnostic categories. The presence of muddy brown granular cast and epithelial cell cast are highly suggestive of intrinsic AKI or acute tubular necrosis, whereas the presence of red blood cell cast with hematuria and proteinuria is suggestive of acute glomerulonephritis. Biuria with white blood cell or granular or waxy cast are suggestive of a tubular or interstitial disease or urinary tract infection. Because serum creatinine is often delayed, research has focused on identifying biomarkers that accurately predict AKI in the early stage of injury. Novel biomarkers include cystatin C, neutrophil gelatinase associated lipocalin, kidney injury molecule 1, interleukin 18, fibroblast growth factor 23, insulin growth factor binding protein 7, and tissue inhibitor of metalloproteinase. These factors show promises in both their diagnostic and prognostic utility in the setting of AKI. However, future studies are needed to establish whether any of these markers will provide beneficial clinical guidance in the diagnosis and management of AKI in children. Other laboratory studies that may be useful in determining the underlying etiology of AKI include complete blood count to look for hemolysis, thrombocytopenia and eosinophilia, complement levels, serological test if indicated, and uric acid in cases of tumor lysis syndrome. Renal ultrasound should be considered in all children with AKI of unclear etiology because it can document the presence of one or two kidneys, delineate kidney size, and survey for renal parenchyma, and it's also particularly helpful in diagnosing urinary tract obstruction or occlusion of the major renal vessels. Kidneys in AKI are normal in size or enlarged with increased echogenicity, whereas in CKD they are frequently small and shrink. Renal biopsy is rarely indicated in AKI, but should be considered when non-invasive evaluation fails to establish a diagnosis. It's commonly indicated to guide treatment when suspected acute glomerulonephritis or suspected interstitial nephritis or suspected lupus nephritis to classify the disease and establish activity and chronicity. Now we'll move to the next part of the presentation, which is management of AKI. Before starting, we need to know that the most important management principle for children with AKI is prevention. So general measures to prevent AKI include fluid administration in hypovolemia, avoidance of hypotension by providing inotropic support in critically ill children following adequate volume repletion, and readjustment and substitution of nephrotoxic medications. So the basic principle for general management of AKI include specific treatment of the underlying cause, fluid management, electrolyte management, nutritional support, adjustment of drug dosing, renal replacement therapy, and specific pharmacologic therapies. We'll go through them in details. We need to keep in our mind that promote consultation and referral to pediatric nephrologist is recommended for the management of intrinsic AKI, especially in the critically ill child. The fluid status of the child varies depending on the underlying cause, comorbid conditions, and possible previous therapy. Accurate initial assessment is required to determine if the child is hypovolemic, euvolemic, or hypervolemic, and guides initial fluid management. Subsequent fluid therapy is based on careful follow-up with accurate records of the fluid input and output, body weight, physical examination, and additional invasive monitoring as needed. Fluid management depends on the fluid status. In hypovolemia, normal saline IV fluid bolus 10 to 20 ml per kg over 30 minutes should be given repeated twice as needed in an attempt to restore kidney function and prevent the progression of a pre-renal AKI to intrinsic AKI. If urine output does not increase and kidney function fails to improve, bladder catheterization is recommended to confirm anuria. In euvolemia, ongoing fluid losses should be balanced by the administered fluid, including medications and nutrition. On the other hand, patients with hypervolemia and signs of fluid overload like edema, heart failure, or pulmonary edema, they may require fluid removal and or fluid restriction. Furosemide can be given to induce diuresis and convert AKI from oliguric to non-oliguric and should be given as a single high dose bolus 2 to 5 mg per kg per dose. In critically ill children, the degree of fluid overload is an independent risk factor for mortality irrespective of the severity of illness, and renal replacement therapy should be considered when fluid overload exceeds 10% with multi-organ failure, oliguric despite diuretics therapy, or require large volume of fluids, and should be performed for those with fluid overload more than 15%, uremic, or with life-threatening metabolic abnormalities. The common indications for renal replacement therapy in AKI include fluid overload unresponsive to diuretics, persistent or severe hyperkalemia, severe metabolic acidosis, progressive uremia, dialysable nephrotoxin, hyperammonemia, and reduction of intravascular volume to facilitate TPN or blood transfusion. Renal replacement modalities include hemodialysis that requires central vascular access, specialized equipment, anticoagulation, and the ability to tolerate large extracorporeal volume. The advantage lies on its ability to rapidly correct imbalance in fluid, electrolyte, and acid-base status. The second modality is peritoneal dialysis, and the advantage of PD include easy performance, no requirement of specialized equipment or systematic anticoagulation, and it is the therapy of choice in neonates and small infants. Continuous renal replacement therapy is extremely useful in patients with hemodynamic instability and multi-organ dysfunction because it allows continuous management of fluid overload without significant fluid shift that may occur with other modalities. The next management step in AKI is electrolyte management. Electrolyte abnormalities are common complications of AKI, and in general, electrolyte disturbances are asymptomatic, so they require routine monitoring for early detection. General measures to reduce or prevent electrolyte abnormalities include: first, patient with oliguric or anuric AKI shouldn't receive potassium or phosphorus unless they exhibit significant hypokalemia or hypophosphatemia. Second, sodium intake should be restricted to 2 to 3 milliequivalent per kg per day to prevent sodium and fluid retention with resultant hypertension. Third, children with polyuric AKI are at high risk for electrolyte losses that should be replaced. Hyperkalemia is the most common electrolyte complication, and it is potentially life-threatening due to cardiac arrhythmia. Children with hyperkalemia may often be asymptomatic, and in those who are symptomatic, findings are usually non-specific and include muscle weakness and nausea. As a result, potassium level should be monitored in children with AKI, especially in those who are anuric or oligouric. Management principles of hyperkalemia include antagonize the membrane toxic effect of potassium by calcium gluconate, promote rapid cellular uptake of potassium by salbutamol and insulin, remove potassium directly from the body by resonium and dialysis, and discontinue source of exogenous potassium like drugs or fluid. This is a nice table from UpToDate showing agents that used to treat hyperkalemia with their mechanism of action and dosage. Now we'll go through a flow chart for the management of hyperkalemia adapted from the Royal Hospital protocol. So if serum potassium level more than 5.5, we need to obtain 12 leads ECG and initiate cardiac monitoring. Mild hyperkalemia is when potassium level from 5.5 to 6.5, and moderate hyperkalemia when potassium level from 6.5 to 7.5, and when potassium level more than 7.5 is considered as severe hyperkalemia. So for patients with mild hyperkalemia and asymptomatic with no ECG change, we need to start resonium 0.5 to 1 gram per kg, furosemide and salbutamol nebulization, and we need to eliminate all potassium from diet and IV fluid. And the reason resonium kept first in the list because other agents are temporary measures that facilitate the movement of potassium, whereas resonium is the ultimate treatment for high potassium level. Then we need to check potassium level within 2 hours. If it is still high, we'll go through the pathway for severe hyperkalemia, or we need to consider other options like dialysis if it is refractory. For patients with severe hyperkalemia or moderate hyperkalemia with ECG change including peak T wave, wide QRS complex, loss of P wave, ST depression, sine wave, ventricular fibrillation or asystole, we need to admit the child to the PICU, start calcium gluconate, start sodium bicarbonate, regular insulin, and of course the other measures to reduce potassium level like resonium, furosemide and salbutamol. High anion gap metabolic acidosis is common in AKI, and it is secondary to impaired renal excretion of acid and impaired reabsorption and regeneration of bicarbonate. In addition, acid production is frequently increased, especially in critically ill patients due to shock or sepsis. Measures to treat metabolic acidosis include IV fluid therapy using Ringer lactate solution or adding acetate to IV fluid, or other option is to use sodium bicarbonate in life-threatening situations. Hypocalcemia is commonly encountered in AKI, and it is due to increased serum phosphate and impaired kidney conversion of vitamin D to the active form. Hypocalcemia is most pronounced in patients with rhabdomyolysis, and is treated with low phosphate diet, phosphate binders like calcium carbonate, and for symptomatic patients, they may require IV calcium gluconate. We need to consider dialysis if increased phosphate is not responding to the treatment. Hypertension is a common complication in children with AKI, and several contributing factors that cause an elevation in blood pressure including fluid overload, renal-mediated hypertension, and often in children with glomerulonephritis. Initial management is typically administration of diuretics. Subsequent management is determined by the severity of hypertension, causes, and response to initial therapy. AKI is associated with marked catabolism, and aggressive nutritional support is crucial to enhance the recovery process. Adequate nutrition includes normal maintenance requirement and supplemental calories to address the catabolic need of the patient. It has been suggested that caloric intake approximately 30% above the maintenance requirement to provide adequate calories in most children with AKI without substantial risk for overfeeding, and infants should receive at least 120 kcal per kg per day, and in older children nutrition intake should be at least 150% of maintenance need. Drug management in children with AKI includes avoidance of nephrotoxic drugs as they may worsen the injury and delay recovery of function, dosing adjustment for renally excreted drugs, and drug level should be monitored for medication for which therapeutic monitoring are available like vancomycin, aminoglycoside, enoxaparin, and digoxin. Now we'll move to the last part of the presentation, prognosis. Pediatrics AKI is associated with increased mortality and long-term morbidity. In US, the overall reported in-hospital mortality rate of children with AKI is 15%. Mortality dramatically increased in children with AKI in the ICU setting, and the reported mortality was 30% over the time period from 2003 to 2010 in the US. The highest mortality rate are seen in infants, with 3%, children requiring critical care 33%, and children requiring dialysis by 27%. Observational studies reported that survivors of pediatrics AKI are at risk for CKD including hypertension and kidney failure. Children requiring dialysis for AKI are at risk for subsequent death and CKD, as illustrated by a retrospective study in Ontario from 1996 to 2017. And this study included death that was seen 6.9%, kidney injury, and 2.6% hypertension, 12% de novo CKD, and 13.1%, and repeated episode of AKI in 14%. So that brings us to the end of the presentation. I would like to summarize by saying that up to 50% of kidney infection may be lost before creatinine even begins to rise, which makes it not an ideal marker for the assessment of renal function. And the most important management principle for children with AKI is prevention. Fluid management is crucial in patients with AKI. Hyperkalemia is the most common electrolyte complication and is potentially life-threatening due to cardiac arrhythmia. CRRT is useful in patients with hemodynamic instability and multi-organ dysfunction. So these are my references. Thank you very much.